I posted your blueprint since yesterday, I
Yes.
think. I don't know. Hi, Fred. I don't know if you have time to even look at it, but I'm gonna pull the screen now. I will be very straightforward. What is in the finals? So at least you have a gift of Christmas from me. Anyway,
Appreciate
so
it.
You're too
I
sweet.
will share the screen now. I just want you to have a positive outlook, okay? You will have a positive outlook. Everything will be okay, hopefully, okay? I can only
Yeah.
hope and pray that everybody will do well in the finals, and that's my hope. Okay, I'm going to share my screen now. All right, so that we can you can take notes and ask questions as I go along with you guys. Okay, I'm going to share my screen now. Where is that final exam blueprint? Blueprint final exam. Oh, here we go. Share screen. There you go. Okay. Here we go. 50 items with you guys first. I will work with Professor Asnes that the first half of the finals will be psych first. I haven't spoken to her yet, but I want it that way so that you guys can go back to OB after you're done with me. Or it will be available at the same time. The two exams will be available at the same time. You have the choice where you want to go first. Okay? But I suggest you go to psych first so that it's fresh knowledge in your head. Okay? So you have 50 items as usual. There are 46 multiple choice with only 2 multiple response. I only put 2 multiple response, okay? And of course, there is 4 math questions. The 4 math questions are very easy. There is no IV. It's a very simple computation, and you can even compute that without using your calculator. All right, so no IV, but I want you to uh, review how to convert pounds to kilograms, kilograms to pounds, and something like that. I think I have one question on that one. All right, now uh, there are no basic concepts. I will start with schizophrenia because all the disorders will be that we have covered, and the ones that I said I will include because you have covered this in the clinical. I have some few questions. I think 3 questions on eating disorder, and I believe I have 3 questions on personality disorder because I know that this was covered, and I posted a very straightforward PowerPoint also on the material. Okay, let's start with schizophrenia. I have 7 questions on schizophrenia. These are the things I want you to focus on. Okay. Um, how do you communicate with patients? For example, how do you respond to a patient who is having delusional thinking? Okay, very important. How do you 2 questions on communication techniques regarding communicating with patients who have uh what you call it, who have alteration in thought process, one who is having delusion and one who is having hallucination. Remember, the key concept here is always acknowledging the feelings generated by the thought process. You still have remember that because I said it's impossible to connect with the thought process, but you can connect with the feeling process. Of course, you acknowledge and then you set the reality straight. Do not argue, do not disagree, do not also confront, and never challenge a patient who has a delusional thinking. Are you with me? So those are the basic things on communication with a patient with schizophrenia. And remember, patients with schizophrenia think concretely. So I have one question that talks about concrete thinking. So you have to kind of review if somebody is thinking concretely, how is that manifested? because patients with schizophrenia don't have the ability to think what? Abstractly. So you have to know the difference between concrete thinking and abstract thinking. Okay? Uh, Positive and negative symptoms of schizophrenia. I think I have two questions on that one. Uh, what are the positive symptoms? Remember, reviewing the positive symptoms, these are the symptoms that are core hard symptoms. So these are symptoms that are in excess: hallucinations, delusions, alteration in thought process, alteration in thinking, disorganized behavior, uh, disorganized speech pattern like neologism, depersonalization, and all those stuff. Kindly review them, okay? Negative symptoms, symptoms that are deficient. So these are symptoms that mostly concern about the affect. So a patient with negative symptoms has deficient. So deficient symptoms: self-care deficit, inability to focus. What else? Patient with negative symptoms, flat affect. So these symptoms are deficient. Okay. Next, I did not even give you any atypical antipsychotics. So the medications that are there are only two medications, believe it or not. I'm so good, am I? So only two medications only, and this medication is thorazine and haldol. So remember, guys, the typical antipsychotic only controls the dopamine receptor. They have nothing to do with the other neurotransmitters, okay? So therefore, with Haldol, the fact that it actually only controls the positive symptom, what are the side effects that you will be looking for? Okay, review the EPS, all of them, from akathisia, dystonic reaction,
Parkinson.
neuroleptic malignant syndrome, and Parkinson-like symptoms.
Yeah.
This will be there. Okay, I think 2 or 3 questions on that one. Now, what is the classic symptom of neuroleptic malignant syndrome? Neuroleptic malignant syndrome is what? Fever, correct? This is my bonus. So this is the most fatal symptom of neuroleptic malignant syndrome anyway, because neuroleptic malignant syndrome happens due to the total blockage of the dopamine receptor. So what does the patient manifest? Fever, right? Alteration in sensorium, the patient becomes confused. So neuroleptic malignant syndrome, EPS, you have to, when do you give cogentin? Because cogentin is the drug of choice during manifestations of this symptom. Okay? When do you give Benadryl? Because Benadryl is indicated for what? I want you to remember this because it is, I think, in your exam number 1, if I'm not mistaken, or exam number 2, Benadryl. Okay, patient teachings about patient, how to deal with, I believe, how to deal with hallucinations. What, you know, how I think so. The patient teachings is, I think, how to deal with hallucination and what are the early signs of relapse on a patient with schizophrenia. Okay? Don't worry so much about the medication. Review thorazine. Remember what I said about thorazine? The main side effect of thorazine, these are the chlorpromazine group, is they are sensitive to sunlight. So one of the question, if you get this wrong, I'm gonna kill all of you because I'm going to give you right now that this is the question about thorazine. Teachings about when your patient is on thorazine, it's photosensitivity. So you know what it is. If they expose themselves in the sunlight without any covering or without any sunscreen, they will burn their skin. So bottom line is, that is the question on thorazine. So that you already have 1 point there because that is my question on thorazine, okay? If you get this wrong, I'm gonna kill all of you because I give you a bonus.
Thank you, Professor.
that's actually a good kill. I will see that the item analysis. If you didn't get, if any one of you didn't get this, I will be so upset. Why? Because this is a very important teaching on Thorazine. Okay. Okay. Depression. I have 8 items. This is a little bit more because here I will give you a communication techniques on how do you communicate with the patient who is severely depressed. What what communication techniques do you think work? All right. Just review them. Making observations, you know, staying with the patient. Silence sometimes work. So I will give you a scenario, which one of these communication techniques is actually applicable in this kind of scenario, okay? Patient teachings on a patient, for example, is on, patient teachings actually is on antidepressants. So unfortunately, you still have to review MAOI. So you know what it is, right? MAOI is still foods to be avoided if the patient is on MAOI, and you know this already, correct?
Yeah, thiamine.
So just review them. They cannot have alcohol, they cannot have certain drugs, they cannot have specifically wine and aged cheese and all of that stuff, okay? And what is the sign of, there is a what you might call it, a serious side effect if a patient is on MAOI and they have taken something. What is that side effect, serious side effect? Still remember it?
Hypertensive crisis.
Very good. And what is the sign of hypertensive crisis? Patient's blood pressure is very, very high, right? And the patient can actually die from stroke. So remember that. Okay, tricyclic antidepressant. Remember tricyclics? I told you this is the most fatal antidepressant if the patient has taken what? If the patient will overdose on tricyclic. Why? What is the serious side effect of tricyclic? What does it do with the cardiac function?
The tricyclic will actually kill you as opposed to the SSRIs that will not kill you.
Very good. Why tricyclic will kill you? Because if you took you never give tricyclic on a patient with history of suicide due to overdose. And I want you to remember that by heart. Never. And one of the things that tricyclic do, because it actually boasts norepinephrine, right? So it causes tachycardia. So what do you have to look for before you start patient teachings on the patient who is taking tricyclics? It talks about cardiac functions, right? So what are the things that you will be teaching your patient while they are on tricyclics? I want you to review that part because tricyclic can be very deadly, okay? Another medication is SSRI. Remember, you cannot get away from SSRI. What is the main action of SSRI? Why do you give your patient SSRI? What are you trying to accomplish? Huh?
Serotonin.
All right. So with serotonin, what do you expect? What is the outcome? Because SSRI is actually the first line of treatment, correct? Why is it the first line of treatment? Because it works fast. Compared to other antidepressant, it works fast. And the desired outcome is, again, this is your bonus, mood improvement. So compared to all the choices that I gave you, this is a straightforward bonus again. So I give you 2 bonuses already. If you will not get this, I'm going to bury you alive. Because this is very, very important. The choice is there. Why is SSRI the first line of treatment? Because it works fast. Because it works fast, its mood is improved. If mood is improved, what is the catch for that? Remember regarding safety? Remember we talked about this in class. If a patient SSRI shows this kind of behavior, what will that indicate to you as a nurse?
Risk for suicidality.
You have to think, because I'm not going to give you the answer. I want you to think about this, because improvement in symptoms, actually, if a patient is on SSRI, does not necessarily mean your patient is getting better, correct? Did you guys get that so far? So
Yeah.
what are the things you'll be looking for in your patient? This I want you to get, because I have given this kind of question also in your exam number 2. All right. Now we're done with depression. Okay. Let's go to mania. Mania is my favorite. We have 7 items in mania. All right. Now, I want you to know, and I want you to review what are the clinical picture of a patient who is on mania, who is on full-blown mania. What are the behavior that you see if a patient is on full-blown mania? And what is true? What when you say patient is bipolar disorder? So what does that mean? So you have to know what does bipolar disorder means. Okay, bipolar. What does that mean? Okay, so it is like a definition. It is one of my select all that apply is about bipolar disorder. Okay. Let's go. Intervention. Oh, intervention during different phases of mania. Remember, during acute phase, patient is very, very hyperactive. So what will be your priority intervention during the first 72 hours? You know this. It is physiological what? Physiological stabilization, which means I want to make sure that my patient will drink, my patient will eat, my patient will sleep, my patient will take medication. This is what the premise I'm asking you to remember. The rest of the stuff is less important, because during 72 hours is what? The acute phase of mania is you want your patient not to die. So I want to intervene. I want my patient to at least drink. I want my patient not to be exhausted. So what are the interventions that are necessary during the first 72 hours? Okay. So review that, because that's very, very important. Okay. During maintenance and stabilization, what do you want your patient to accomplish? Okay. The goal here is, of course, medication adherence, and that's the premise of everything else. Know again about lithium. Lithium, you cannot get away from lithium. Just put in your mind, what is the therapeutic level of lithium? What is the, if you know that, I give you a level. Tell me if this one is within therapeutic level or this one is toxic level. So you have to know that, unfortunately, of all the drugs that I want my students to remember by heart is lithium. Why lithium is very fatal. All right. Unfortunately, I have to include lithium in your finals because lithium is always in the NCLEX. Okay, so lithium. Suppose your patient cannot take lithium. What is the second line of treatment? Another bonus, number 3. The answer is Depakot. So I gave you 3 bonuses already. If you don't get this, I will throw you out in the ocean. Why? Because I gave you all what's in there. So Depakot is the second line of treatment. Your patient is toxic, is allergic, or whatever it is, cannot take lithium. What will be the second line of treatment, which is Depakot? So Depakot is anti-seizure, you know that. And however, if you gave it to patient with, for example, patient with mood disorder, it's the mood stabilizer. All right. So I'm done with lithium. I did Depakot. Just review the communication techniques again in a patient with acute mania. So that's my seven items in there. Now, cognitive disorders, delirium, dementia, 5 items. No medication there for cognitive disorders. It's just, unfortunately, you have to review the different stages, stage 1, stage 2, stage 3, and late stage, and what behavior is being manifested, because I have intervention question there. So if you don't know what actually is being manifested in stage 2, then you don't know how to intervene. So stage 1, what is the classic uh, symptom during stage 1, right? Forgetfulness. Stage 2, patients starting to be confused. Stage 3 and stage 4. Stage 4 is the last stage. So you have to know the intervention in every of this stage. So if a patient is showing aggression, how are you going to deal with that? You start with the least restrictive, correct? So if a patient usually during stage 2, between stage 2 and 3, because they are so confused, they manifest aggression. Why? Because they cannot remember a lot of things. So review what is confabulation, because confabulation will be in your finals. So if a patient confabulates, how are you going to deal with that? Because confabulation is a defense mechanism which is manifested between stage 2 and 3 because the patient cannot remember. So patient is telling story about something. So how are you going to deal with that? Okay. Another thing also is respite care. What is it? So why is respite care a concept that you need to know when you are dealing with patient with dementia? What is it? What, for whom it is indicated when somebody is getting respite care? Is it for the patient or is it for the caretaker? Why? And I want you to read about respite care and what is the most important with nursing intervention. If a patient is placed on respite care, is you don't want the patient to be more confused, so that as much as possible, this is another bonus, and I want you to listen to this. You have to have a consistent caretaker. That is exactly what it is when a patient, for example, goes to the hospital, right? And because you want to give a break to a caretaker, so a patient should not have increased confusion. So whoever is taking care of the patient should be consistent during the period of time that the patient is on respite care. I give you 4 bonus already. Okay, next also is what is the difference between delirium and dementia? What is the outcome of delirium? Why is a patient developing delirium? Review this first. Review this. This is very important. So with delirium, you find the cause, patient go back to pre-delirium functioning. So what are the cause of delirium? Please review them. It is one of the questions actually. Why does the patient goes into delirium? What is the early sign of delirium? Which one is chronic? Is it dementia or is it delirium? Which one is acute? Is it delirium or dementia? So guys, please review this, okay? I give you specific things to review. That covers my cognitive. Substance abuse, only 6 items, believe it or not, and these are very easy questions. The same medication that I gave you for midterm are the same substance I'm going to give you in finals. Isn't that a good thing? I don't want you to worry about those things that are not very common. So know the signs of alcohol withdrawal, delirium. Know the signs, because alcohol withdrawal delirium is a medical emergency. What are the signs of alcohol withdrawal delirium? So if you know the sign of delirium, the sign of alcohol withdrawal delirium is almost the same. Those autonomic hyperactivity. What are those? When I say autonomic hyperactivity, anybody know what autonomic hyperactivity is? Alice, do you know? Hi, Alice. Do you know what autonomic hyperactivity is?
Hello. Autonomic hyperactivity is like sweating, heart
Yes.
tachycardia,
Yes.
probably increased respiratory rate.
Could be. What about
Maybe.
hallucination? What type of hallucination is present there? Tactile. Come on, guys. Tactile
Tactile. Oh,
hallucination.
right.
And some of the patients will also have illusion. So these are the things that can happen, which could pose a great safety risk for the patient. So remember, alcohol with early signs of withdrawal, you know, when is it happening? As early as 6 to 8 hours after the last drink, correct? Then if it is not treated, it will progress into alcohol withdrawal delirium, also known as delirium tremens. And this is what are the signs. Alice just say autonomic hyperactivity. So know what they are, okay? Because one of my questions is about that, and I want you to know this. So my CNS depressant is of course alcohol. Alcohol is my CNS depressant. I gave you some of the things that you need to look for. Heroin. Heroin, intoxication, you have to know. I think one of my select all that apply is heroin and heroin intoxication. You have to know what is the manifestation of heroin intoxication. And another question is heroin withdrawal. Know it by heart. Patient is no longer having the substance in their body, so the manifestation that you will see is CNS stimulation. Correct? Right? Yes? So,
Yes.
but if the patient is abusing a CNS stimulant, for example, uh, cocaine.
Okay.
Cocaine is there. One question is on cocaine overdose. Know what it is. And cocaine withdrawal. Okay? Because if you are abusing on a substance, it's no longer a CNS stimulant, it's no longer in your system. So CNS stimulant withdrawal is depression. So the patient goes into suicidal crush. Are you with me? Cocaine is the only stimulant that's in there. And what is the purpose of AA? It's also a bonus. You know what it is. You all went to your AA. Why is AA important? Methadone. What is the main action of methadone as a drug of choice for opiates withdrawal? Why do you give that to patients? So review about methadone. Okay, and that's my 6 items. Let's go to personality disorder. I know that personality disorder was covered somehow a little bit in clinical. I know that your clinical instructor told me you covered personality disorder a little bit. So the personality disorder that will be there are the most common one, only 2. But I have 3 questions with 2 personality disorder. The borderline, right? Borderline personality disorder. What is the main defense mechanism? Again, please find this out. What is the main defense mechanism that is manifested by patient who is borderline, with borderline personality disorder? Please review it. I gave this to you. I know that because I'm taking notes. And I said this type of behavior is always seen in patient with borderline. Remember that behavior where there is no gray area, it's black, either black or white. Yeah, this you know. Please review this because this is important manifestation of patient with borderline. Borderline personality disorder. In general, all patients with personality disorder, what is the classic picture of all of them? Okay, that's why they're called personality disorder. Antisocial personality disorder. What is the classic symptom when a patient has antisocial? Because these guys are charming. A lot of them have a very good in the antisocial personality. They're very good in manipulating you, in coning you. These are the cone artists. They know how to get you. They are manipulative. They are intimidating. They don't have a conscience. their happiness actually is making you suffer because these are the people who steal your identity. These are the people who are you know, most of the patients who are addicted to drugs and alcohol have antisocial personality trait. So how do you deal with them? You have to be firm and actually know how to set limits on the behavior because they know how to con you, they know how to manipulate you. So that's antisocial personality. Okay, just think about someone in the unit who knows how to get his things way because they have antisocial traits. Okay, these are the con artists. They steal your identity. They know how to manipulate you. And they are very charming and very ingratiating. A lot of them are good looking. So you can kind of fall into their trap. So what is the technique? Set firm and consistent limit setting works with them. Okay? Uh, Eating disorder, 4 items only. So anorexia and bulimia, what are the symptoms of anorexia? What do you see? I know you had a very good Professor Dorovitz did a very good presentation of anorexia nervosa. Which one is severely malnourished and which one has normal weight? Okay. What do you see? What symptoms do you see in patients with anorexia? But they have one common nursing diagnosis, which is what? Anybody tell me? It starts with disturbed body image. So if they have disturbed body image, even if they will die from physical complications, they are still considered mentally ill. Why? Because they have disturbed body image, correct? So how would you communicate with them? The same communication pattern that you have with antisocial people. They need to be told directly the way it is. Why? Because a lot of patients with eating disorder have also borderline personality traits, right? So a lot of patients with eating disorder, some of them they cut themselves. Also, they have history of abuse. 90% of the time, patient with eating disorder have history of abuse. So you need to know really how to uh, communicate with them in a way that they will eat willingly. Unfortunately, sometimes you have to have a behavioral contract with them, but you have to build a therapeutic alliance with them, and that's very important. Bulimia, people who vomit, like so you have to know what are the classic manifestation of a patient with bulimia. So patient with bulimia actually they have enlarged parotid glands, correct? And also they have their teeth. Remember the teeth? They have dental caries because of the acidity. They vomit all the time. And what do you find here? Callus on their hand, because if they use their hand to vomit, so sometimes there are bite marks in their hand. So that's one thing. Nursing intervention is, of course, your goal is you don't want your patient to die, right? But your goal eventually is to have because they have disturbed body image, so they will. Your first assessment actually is ask how they view themselves. It's very important, and then, of course, they have distorted body image. But how are you going to accomplish your outcome with that one? So your first is once the weight is stabilized, they gain the weight, then this patient needs a lot of psychotherapy. Just like what you guys need. They need cognitive behavior therapy, just like most of you need at the moment, because now most of you after OV have distorted body image now. You have distorted cognition, that everything will fall apart, and that is actually distortion. So you have to change your in order for you to have a change in your perception and before you can impact change in behavior, it should be here, right? So cognitive behavior therapy works with these people. Crisis management, believe it or not, only one item, and that is know what is crisis intervention. What is the goal of crisis intervention, right? And that's one item with crisis intervention. There is no types of crisis there. It's just one question on crisis intervention. Um, Anxiety, anxiety disorder. Okay, anxiety disorder, only 3 items, believe it or not. How is generalized anxiety disorder manifested? Because it's GAD. The one that's in this exam is GAD. You know what it is, right? Generalized anxiety disorder. Remember what I said? Patient with anxiety disorder, they are not able to manage high levels of anxiety, which leads to psychological conflict. They have to manage somehow. With generalized anxiety disorder, they manage by extreme irrational worrying. Correct? Yes? With OCD, rituals. Correct? They manage psychological conflict by rituals. It's only, it's, oh, GAD. Oh, I forgot. One more here. I think it's GAD and OCD only. And interventions during different levels of anxiety. So for a patient who is on the panic level of anxiety, what is your intervention? What is your intervention on a patient who is extremely uh, worrisome, like high levels of anxiety? What is the goal of that? What is your goal? Remember, your goal is to lower the patient's anxiety level to a level that you can connect with the patient. Remember, the higher the anxiety, the greater the cognition actually closes. The higher the anxiety, the more the cognitive level closes. So therefore, when your anxiety level goes down, cognition also opens up, because the lower your goal is to lower the anxiety level. Okay. Actually, that's it. We're done. Any question?
Professor, what about suicidal thoughts
Think
and
you can get 90 and with the psych portion? Do you think you can get 50 items correct? Because it's, remember it's 50-50. I have 50 questions, which is 1 point only each, plus 50 questions also on Professor Asnes. And
And then those who have the extra 2 points, we can
the
use
2
them,
points
right?
is, I will add it after I am done adding the psych portion, because I will be tabulating your grade anyway. I will add the 2 points for each one of you. I think only one person told me they want it done, but I said no, wait until the finals. I
Professor,
haven't added anything yet to any one of you. So all of you will get 2 points for the finals. Tencent, yes.
Professor, for the suicidal thoughts and behavior, we don't have that, right?
No.
Ale?
Wait, it's on our blueprint. Go down on your blueprint.
Where? Which page?
It's the next.
Where is that? In
Can-
depression?
At the end of the
No, there's
blueprint.
one more topic after anxiety.
Oh, there is more topic? Why do I have only this one? I'm so bad. Why do I only have this one?
Scroll down.
Scroll down.
Press the
Oh, Jesus. There you go. Suicidal thoughts and behavior, 2 items. What are the risk factors for suicide? And that you know, right? So how do you have to know which one is what is this? There are 2 signs, there are 2 verbalization of suicide. The one that is obvious, and the one that's overt, and the one that's covert. So how do you deal with a patient's verbalization? All verbalization of suicide should always be taken seriously. That's my number 5 bonus. So I give you 5 bonus already. That's it, only 5. And if you didn't get this, you were not listening, because this is what it is. When I tell you this is what it is, it will be there. Okay, and another, there are 2 items on the like risk factors, and you know that if it is a single white male compared to someone who is married, so married is protective and being single is risk factor. In addition to that, in here, I forgot to add here in mania, I think I have 1 question on aggression. If a patient is aggressive, how would you deal with that? Okay, so remember what we said about restraints and seclusion. When do you use that? And what are your criteria when using that? I think it's because it's here in mania. That's why there are 7 items. So aggressive behavior, how do you deal with aggressive behavior? If a patient is showing aggression, whether the diagnosis is schizophrenia or the diagnosis is bipolar, how are you dealing with aggressive behavior. Okay? You always have to see whether there are enough people before you approach a patient. Never approach a patient alone if the patient is showing signs of aggression. So even if a patient is only threatening, the patient is saying, if you will not be in front of my face, I'm gonna kill you or I'm gonna hit you. So take all threats very seriously, even if a patient has history of aggression. So you have to remember that the greatest risk factor for aggression is if a patient has previous history of assault. So you have to remember that. I think I have a question on that one also. I've given you all that I can give you for this reason. Also, oh, I forgot, you have to know the Cogentin and Benadryl. I told you already, right? So Cogentin, Benadryl, Thorazine, Haldol, those are the only medications that I want, and of course, lithium. I tried my best to make your finals as easy as possible. Why is that? Because
Thank
at
you.
least you can recover. You can recover your losses. It's like you're getting bankrupt now. So there is a solution for bankruptcy: recoup. And final exam in psych is a recoup for you. Okay? I want you to do well. I really wanted you to do well. So in order for you to focus, start with
Bless your
psych.
heart.
Thank you, Professor.
It will break my heart if
You're
you
an
will get
angel.
60. If any one of you get 30 out of 50, I will be so depressed. And my Christmas will be a crying time because I don't have any of my students getting 30 in my 50 questions. The lowest that I have in my final so far is 40. 10 wrong is the max that I give allowance to my students. Why? Because if you're still getting 30 in the final, that means you're not learning anything. That's why I have repeated most of the questions that I think you really have to know. I don't want my I don't confuse my student. I prepare my students to face third semester. By even if my question is a little hard, I want you to kind of apply what you have learned from the 3 exams that you already have. So this is the accumulation of everything that you have learned, communication techniques, and all of that stuff has to be applied now. Okay? If any one of you will get 30, I will be so sad. So please, your goal, I'm gonna get at least 40. 40 is plus 40 with ASNES, so you get 80 in the finals, all of you will pass. Isn't that
We're
a
gonna make you
wonderful
proud.
thing to look into? All right. Any more questions for me? Because she's coming back at 12:15. Also, regarding HESI, I know, Jasmine, you're the only one who have told me that you are thinking of getting it remotely. And I understand that, especially with the kind of environment that we have now. I'm still waiting for Professor Eng to give me directives on how much and how are you going to do it on your own. Remember, if you're doing it, you have a different, I believe you have a different access code, and I will make that happen today. I will give you all the logistics as soon as I know. Okay?
Okay.
But for the rest of you, make sure you have registered by the instructor code. I know there are 19 students as we speak, there are 19 students that have registered to take the HESI tomorrow. I don't know, I don't have access on who these people are until I activate and proctor tomorrow, then your name will pop up. So please, not only register for one, register for both. So ours is 211091 maternity and 211091 psychiatry. And that is for tomorrow. Please do that before before the day is over, because I want to make sure that everybody is on tomorrow. Remember, our HESI is 9 o'clock tomorrow for those who are taking it in campus. 603 and 605, S603 and S605. Did you guys get that? If you cannot access, then I will have a problem tomorrow. And some of you who are still contemplating or whether you withdraw or off from an NC, The guidance is extremely difficult for me to tell you what course of action you will do. But the only thing that I can tell you, if you opt for an NC on December 13, you will get the finals. But if you opt for a W, you cannot get the finals. So it's really your call. Okay. Regarding buying the HESI, I know some of you have voiced, there are quite a few, maybe 2 or 3 who have not really sent me the receipt. They're not in the list. So they said if they will opt for an NC and they will not take the HESI, what's the recourse for that one? I'm waiting for Professor Ing to tell me. Okay. So before the end of the day, I should have answers to that already. All right. So I hope I made your life a little happier for all of you.
A lot happier.
And I expect everybody will get 40 at least. Or if you could get 45, I will be jumping with joy. That means that what I'm teaching you is finally kicking in. All right. So 45 piece of cake. I had a student who actually got 48 in my final. I said, oh, hallelujah. I am so happy. I'm so happy. That means that she's getting what she's supposed to learn throughout the semester. Okay. And the math is very easy. I just want you to know how to add and subtract and multiply because it's very, very, very easy. There's no IV, none of that. Any more question? She's coming back at 12:30.
Professor, my 2 points, I want them for the final.
I will. I'll add everything because I'll be the one adding your finals anyway. I'll add everything. Plus, if you get 800, oh my God, they changed the benchmark. If you get 850 in HESI, in Psych and 850 in OB, you'll get 5 more points for finals. That is if your general average is passing. Supposing I add everything and you got 73, then that's okay. I will 73 with my addition of 2 points, so that's 73, right? Then I can add the 5 points. But if your overall average is a 70, then 5 points will not be added. Because the 5 points can only be added if your overall average after everything is tabulated is passing. Did you guys get that so far? Yes, Jasmine.
I wanted to ask, so we have to pass both Psych and maternity to
No,
get
you don't have to. You don't have to. What I'm saying, because it is one course, suppose you're after tabulating everything, finals is over, tabulating everything, you have 72.5, you pass. Then I will add 5 more for your final exam. Supposing your final is a 40, is an 80, then you get 85. Are you with me? Isn't that a wonderful thing? So think about that. You still have your lifelines attached. Okay. So that is something you need to rejoice. It's Christmas time. Don't be sad. You have to be glad. Okay. I will see you tomorrow, 9 o'clock. Jasmine, I'll get back to you before the end of the day. I'll give you the records.
Thank you, Professor.
Okay.
Thank you.
Thank you, Professor.
Okay, bye. Bye, guys.
Have a great day.
Remember
Thank
what I
you.
told you.
Bye.
I'm gonna bury you alive if those 5 questions are not answered. And if you insist, this is what pisses me off. If I say this is the first line of treatment and you insist that you have your own choice because blah, blah, blah. So what did I tell you? Okay. Like the 171, they keep on fighting to me that the first line of treatment for mania is Haldol. And I said, where did you get that idea? And I said, one of the test bank, blah, 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 blah. And I said, then you're not listening to what I'm telling you. So when I tell you the first line of treatment is lithium for mania, why will you insist on your Haldol? Are you with me? Because they read it somewhere else. And I said, you read it somewhere else, but what you gather from somewhere else makes your life miserable. Why? Because Haldol is never the drug of choice for acute mania. Are you with me? Now you know what Haldol does, right? Yes. Okay.
Professor, Sherpa questions are still a good choice, right?
What is it?
Sherpa, the questions. Yes.
Yeah, do your share path.
Yeah.
It will help you do very well in HESI because the share path questions are similar to the HESI that you will get
Okay.
tomorrow. So please, if you have, do as much the one that I assigned you and the ones that are
Yeah.
here.
Okay.
Just for because that is exactly the kind of question they're gonna give you. The way they phrase it, the way they put it, it's the same. So if you do that, it will be a good advantage for you, so you know what kind of questions Sherpa HESI will be. Okay, you have access to that anyway for both maternity and psych. Okay, guys.
Okay.
Okay, thank you.
Yes, Professor. Thank you.
My husband is just texting me. The patient that I'm caring right now just stayed positive. I think I will be quarantined, including yourself.
What?
Oh no.
Because he still works. He said, my patients tested positive for COVID, and I was told that I will be in quarantine. Jesus. What
Oh
about
my
me?
gosh.
We sleep together. Will I be in quarantine too? This is actually my problem because my husband is still work in the bedside, right? So he carries with me, although we are very careful here in the house. You never know what you carry in, right? So
Yeah.
then I have an excuse not to show up to HESI tomorrow. I'm on quarantine. So you don't have a proctor tomorrow. I'm just kidding.
Oh my
I'll
God.
be there. I'll be there. I'm actually having myself tested every at least every other week because my antibodies is now 0. Remember, I got sick in April. The antibodies is really good for 4 months only, and that is evidence-based. So do not be assured once you have COVID that you are immune for life. No, that's actually not true. So I started with, I think, 9. In April, I tested a week after I got better. I think 9 or 10. Oh, the level is like that. I tested like 2 weeks ago. The lowest is 2. Mine is less than 2. So what is that telling you? You're negative. That's nothing. So that's why I'm extra careful still. That's why I'm happy. I wish our HESI is actually done remotely because I don't really want to take the train and go to Manhattan because I have lots of risk factors myself. Okay, so guys, I'll see you tomorrow. Any more questions?
Tomorrow.
Just email me if you think about something, okay?
Okay.
Everybody is like tired and they're already on the exhaustion phase of alarm. The alarm stage is over, so now you guys on your exhaustion stage.
Literally.
So these two will pass. So just maintain a good positive outlook. Take care of your mental health. Take care of your physical health, and we are all in this together. Okay, I'll travel with you. I've been traveling with you all the way. So I hope that we will reach our destination and everybody will be successful. That's actually my prayer, that everybody will pass. Can you imagine if you will be repeating this and you will still be online in the spring? It's the same kind of struggle that you guys are having now. Clinical is not yet sure whether we can go in the hospital. So it's still so like this. So I'm hoping that everything will be better and that the vaccine will be out soon. Hopefully. Hopefully by first week of January, it will be there. I have already a notice from NYU because I go to NYU Langone. Make an appointment now. Vaccine will be here. I said, oh my God. Well, how proactive could they be? Make an appointment now for your vaccination. Okay, dokie. I gotta go. For those who wants to talk to me, can call me on the phone because at 12:30, Professor Asnes will come back. Okay. Bye, guys.
Thank you.
Make sure you register for HESI. Okay.
Yes.
I'll see you tomorrow. I'll see you tomorrow in the flesh. Except for Jasmine. If there are anything else, Jasmine, I'll inform you immediately. Okay.
Okay.
Gotta go. Bye, guys. I'll stop sharing now. I think Professor Asnes is here in like